Alaikum rahmatullah. Good evening, everyone. It's my pleasure to be with you today and tomorrow, inshallah. And it's my pleasure to be with Dr. Majid Bakhi today. He's a consultant, stroke neurologist and neurorehabilitation. And Dr. Saeed Zahrani, he's a stroke neurologist and a neurointerventionist, King Fahd Hospital, Jeddah. And Professor Helmus Schmidt, he's a Chairman and Professor of Neurology, Goethe University Hospital, Germany. And I would like to thank the organizing committee for arranging this symposium. I would like to share a few slides as an introduction before starting our perfect speaking.
Dr. Mustafa, there should be a share screen option on your screen.
Yeah.
On the downside.
Yeah. I will open the presentation. It's okay.
Yes.
Today our agenda will start 7. I will just give you a review of a few slides about stroke in South German Hospital. Then Dr. Majid Bakhit will speak about assessment of acute stroke in emergency room. Then Dr. Saeed Zahrani, he will talk about stroke code and stroke units. Then Professor Helmus will speak about update on intravenous thrombolysis and secondary prevention. Just I want to give introduction for a few seconds. This stroke is a medical emergency, and stroke occurs when the blood supply to a part of the brain is interrupted, and the lack of the blood supply means that no enough oxygen or nutrients reaches the brain, and the brain cell become damaged or permanently destroyed. Depending on which part of the brain is affected, different symptoms occur. A stroke is a major public health problem. Nearly 6 million people die each year from a stroke. 1 in 6 people on average will suffer a stroke in their lifetime, and every 6 seconds, someone dies from a stroke. The stroke burden in Saudi Arabia. A stroke is the second leading cause of death in Kingdom of Saudi Arabia, compared to USA, which is the 5th leading cause of death. About 14,000 deaths in 2012, as per WHO, and about 25,000 new strokes in Kingdom of the KSA per year. Every 15 minutes, someone will develop a stroke, and expected to increase by 50 to 60% by year 2030. The healthcare services in the kingdom have improved greatly in the last decade, and many specialist units have been established to provide stroke care, but still at least 1% of the ischemic stroke receive intravenous TPA compared to 6.5% in the United States. The good news is that there is an effective treatment which can help to improve and decrease the severity of acute stroke, and stroke can be prevented by treatment of the risk factor. And this is the core of our lecture today by our speakers and professors. The timeline of the stroke timeline started in 1995 after approval of the TBA after approval of the TBA. Then after the 5 important studies for endovascular thrombectomy after 2015, the era of thrombectomy became more established. In South German Hospital, we started giving TPA for our stroke patients since 2003. Then in 2017, we started to do thrombectomy for our patient with large vessel occlusion. In 2019, we opened our stroke unit. And in 2021, we updated our stroke program and updated our stroke pathway admission sheet order set, developed our stroke code and stroke committee, and updated our performance measurement and KPIs. Training, orientation of our staff, ER, ICU, and anesthesia team, and we did some, we did the patient and family education and the community awareness. And this is our colleague, Dr. Ahmed, Dr. Gadi, Dr. Sharawi, Dr. Anani, and Dr. Majid, Dr. Fawazi are giving a lecture and workshop for our staff in the hostel. And this is our stroke, our stroke team. And Alhamdulillah, by June 2021, we have joint JCI accreditation as a primary stroke unit in Jeddah. Okay, this achievement is not neurology only. This work is a team of starting from the hostel and administrative support, the stroke unit and the stroke team, nurse and doctor, emergency department, ICU and anesthesia, radiology department, laboratory, neurosurgery, nutritional department, social worker, educational department, as well as quality management. This all work together to achieve this JCI accreditation of our stroke unit as a primary stroke center. Thank you. And now we'll start the first lecture of Dr. Majid Bakhit. Dr. Majid, you will start now?
Yes, sure. Thank you, Dr. Mustafa. And I will share the screen. Bismillah ar-Rahman ar-Rahim. It's my pleasure to talk about stroke, and will be with my colleague Dr. Saeed, Dr. Mustafa, and Prof. Hilmat, and inshallah it could be a good night for this huge number of information of stroke. Today I will talk about the emergency ER assessment and management of acute stroke patient. The hyperacute management and TBA will be Dr. Prof. Helmet will talk about, and the stroke code Dr. Saeed will talk about, but how the physician and ER physician and medical doctor can deal with the stroke, especially in the area there is no neurologist or stroke neurologist. As you know, stroke is one of the leading cause of disability, mortality, and morbidity worldwide.
Dr. Mazid, sorry to interrupt you. Can you please share your screen? We are not able to see your screen. You may see now option share screen.
Yes.
Okay. Please click on share screen, and because we are not able to see it.
Okay. Is it clear now?
Just wait.
Yeah.
We can see it now.
It's clear now. Yeah.
You please make it full size. Yes, perfect.
Okay. Stroke is one of the leading causes of disability, mortality, and morbidity worldwide. Although stroke was traditionally associated with few treatment options, the introduction of a number of evidence-based intervention has improved patient care and outcome in the recent year, starting from the IV TBA, mechanical thrombectomy, wake-up stroke, using of the technology beyond like MRI or CT perfusion beyond 4 hours and 30 minutes. So now every years we have a good technology which improve the outcome and treat the patient with a stroke. A stroke is not, as Dr. Mustafa said, is not only for the stroke for neurologists, but also is a teamwork. And this is the recommendation of American Heart Association and Stroke Association, that it must be organized protocol for emergency education of the patient with suspected stroke is recommended. So we start with the triaging paramedics, triaging nurse, ER physician, neurologist, and also radiologist. So all of them, there must be a protocol and organized team, including all physicians and nurses in the emergency room, to deal with those patients who have acute ischemic stroke, because brain is time. So minutes differ in the in the injury of the brain. The phases of treatment of stroke, we have 3 phases: acute, assessment, and management, and this is in the first few hours in the emergency room, and then subacute assessment and management when the patient transferred to the stroke unit to see the cause of the stroke, and also treat the stroke neurological complication or stroke medical complication. And then the long-term assessment and management, this is include rehabilitation and return back the patient to the community, and also functioning well after discharge from the rehabilitation center. Long term, we have a short term rehabilitation, and which includes 6 weeks, and then long term rehabilitation. Assessment of the patient in the acute ischemic stroke, this is include initial assessment, stroke management issue, blood pressure management, acute therapy, and the prevention of complications. So initial assessment, this is include the goal in the initial phase include ensuring medical stability with a particular attention to airway, breathing, and circulation. Some patients with acute ischemic stroke, mainly the hemorrhagic stroke, came with instability of the vital signs. Quickly reversing any condition that are contributing to the patient problem, and minimize brain injury. One of them, high blood pressure, hyperglycemia, fever, all of these can affect the outcome of stroke patient. Determine if the patient with acute ischemic stroke are candidate for thrombolytic therapy or endovascular therapy, and this is depend on the CT scan, the CT angio of the patient. All of these, we have to answer it quickly, and moving toward undercovering the pathological basis of the patient neurological symptom, and to search the cause of the stroke. Some patients, they may have atrial fibrillation in the emergency room when we do ECG. All of these initial evaluation required a rapid and very rapid but broad assessment to not forget anything. The airway, breathing, and circulation especially is important in intracranial pressure due to intracerebral hemorrhage, vertebropatellar ischemia, or bihemispheric ischemia, because all of these can cause loss of consciousness, and the patient may deteriorate very fast. Oxygen saturation monitor is very important also. Low oxygen saturation can increase the size of infarction. Also, in the initial assessment, we have to have the history and physical examination. The time of ischemic stroke symptoms onset is critical, and also the time the patient was last known to be awake and free of symptom of stroke symptom. This is very important. As we know, the window is a little bit limited, 4 hours and 30 minutes, but with the endovascular can extend to the 40 to 6 hours. And sometimes we extend to the 24 hours, depending on the patient situation and the neuroimaging. We have to keep in mind some of the stroke mimicker, like seizure, syncope, migraine, hypoglycemia, or drug toxicity. And it's very important to look for stroke and to not miss the stroke if the patient came with seizure. We have one story last 3 months. The patient has cardioembolic, and then he has a seizure. After that, he developed left-sided weakness, but when the patient passed the window. First, it's very important to assess the patient carefully in the emergency room, and the risk of bleeding. If the patient has a seizure or a migraine and develop and receive TBA, the risk of bleeding is less than 2%. As we know, ischemic stroke is more common, 80 to 90%. Intracerebral hemorrhage is 10 to 15 or 20% of the cerebrovascular disease. Also, in the assessment or physical examination is very important. We examine the neck vascular fluid, palpation of the pulses in the neck, arms and legs, heart, skin, and extremity. It's very important to look and palpate these vessels. Sometimes patient may have mesenteric artery occlusion or large vessel occlusion in the extremity and may mimic the stroke. Neurological examination, we have to know the ischemia in different vascular territory. The stroke subtype is very important, cortical or subcortical, and the most important, National Institute of Health Stroke Scale, and this is specific for stroke patient, differ from the usual neurological examination. This is the NIHSS score. It is 11 item scoring system. 5 to 7 minutes must be completed. Sometimes we use less than this. A maximum score is 42 and the minimum score is 0. And this is how we calculate the NIH score. Usually you use the iPhone and we can calculate it very quickly, and sometimes we also measure the dose. The severity of stroke depends on the NIH score. No symptoms is 0, and minor stroke is 1 to 4. Moderate stroke 5 to 15. Moderate to severe 16 to 20, and severe stroke is 21 to 42. This is the severity of stroke by NIH score. But sometimes, if the patient presents with the aphasia, the maximum score is 3. That means the patient has minor stroke. But in reality, is a major neurological deficit, a patient candidate for IVTBA. Otherwise, we will give mute and aphasia. If the patient has a neglect, the maximum score for neglect is 2, but the neglect is a major neurological deficit. If the patient has a visual field defect, all of these are a cortical sign. It's very important to know and thrombolize these group of patients. Otherwise, they will live in disability. And don't say this is a minor stroke, is not candidate for IV TBA. Also, in the initial assessment, we have investigation. Urgent investigation include non-contrast CT brain or MRI if the patient has a wake-up stroke or a stroke of unknown onset. A CT angiogram is mandatory to look for large vessel occlusion. Finger stick blood glucose, also very important, one of the most common mimicker of ischemic stroke. Oxygen saturation, low oxygen saturation can lead to increase the volume of ischemia. Other immediate tests, ECG, complete blood count and platelet, cardiac enzyme and troponin, serum electrolyte, prothrombin time, and INR if the patient on warfarin, activated thromboplasmin time. All this is depend on the other tests important in the for stroke patient. Also, a CT scan is very important. It must be initiated once the patient arrives to the emergency room within 15 minutes. We have aspect score, which is very important. If aspect score is low, that means the patient may have a high risk of hemorrhage after TBA. The more the normal, the near normal, the aspect score is the good for the patient. And we have also the early sign of ischemic stroke. And we counted by supratentorial and infratentorial. Also, a laboratory study are appropriate in selected patients, like liver function test, toxicology screen if the patient is young and have a stroke and suspect of drug, blood alcohol level, pregnancy women with childbearing, pregnancy test in women with childbearing potential arterial blood gas if the patient suspect hypoxia, chest radiogram if the patient has a disease in lung disease, LV puncture if there is a subarachnoid. So it depends on the situation of the patient, and EEG if the patient are if the seizure is suspected. Then we go to the stroke management issue. We have to make sure the patient has a good hydration, fluid, hypoglycemia, hyperglycemia, swallowing assessment, head and body position, fever, and stroke unit care. Fluid intravascular volume depletion is frequent in a setting of acute stroke, particularly in elderly, potentially may worsening the cerebral blood flow. Isotonic saline without dextrose is the agent of choice for intravascular fluid repletion and maintenance fluid therapy, because fluid which contain glucose will increase the lactic acidosis, which enhance or lead to increase the size and volume of infarction. So a patient need free fluid not contain glucose. Avoid excessive free water, which exacerbates cerebral edema in acute stroke. Avoid fluid containing glucose, as I mentioned, which increase or exacerbate hyperglycemia and more lactic acidosis. Fluid management must be individualized on the basis of the cardiovascular status, electrolyte disturbance, and other conditions that may disturb fluid balance, especially in those patients with heart failure or low ejection fraction. Hypoglycemia, vocal neurological deficit mimic stroke. Severe hypoglycemia alone can cause neuronal injury if not treated early. It is important to check blood sugar and rapidly correct low serum glucose if it is less than 60 milligram per deciliter, because if not corrected very fast, it can lead to irreversible neurological deficit. Normoglycemia is the desired goal, while avoiding marked evaluation of the serum elevation of serum glucose. Hyperglycemia, also one of the stroke mimicker and can affecting the basal ganglion, may mimic the stroke. Blood glucose level more than 126 milligram per deciliter is common in the patient with acute stroke and is associated with poor functional outcome. Also, hyperglycemia with IV TPA can increase the risk of hemorrhage. In a series of 59 patients with acute ischemic stroke, admission hyperglycemia was presented in 32% of the patients without diabetes, 81% of patients with diabetes. Stress hyperglycemia may be also common in stroke patients, and the neurodiagnosis is also important in some patients with acute ischemic stroke in the emergency room. Hyperglycemia may augment brain injury by several mechanisms, including increased tissue acidosis from anaerobic metabolism of free radical, increased blood-brain barrier permeability. Acute hyperglycemia is associated with the reduced salvageable of penumbral tissue and greater final infarct size by neuroimaging, and some patients we found that the patient may deteriorate rapidly and rapid well-established infarction. Maybe we see it in the CT scan. Hyperglycemia is associated with reduced benefit from recanalization with the thrombolytic therapy and high odds of symptomatic intracranial hemorrhage. Tight control of glucose with intravenous insulin does not improve the functional outcome in acute stroke patient, but also we don't want a high reading of glucose. Swallowing assessment common after stroke and is a major risk factor for developing aspiration pneumonia. It is important to assess the swallowing function prior to administration of any oral medication or food to prevent of aspiration. NPO or is status until swallowing function is evaluated. We can evaluate the patient in the emergency room, or we can ask the nurse to do the swallowing assessment, and then we ask the swallowing team in the next day. Head and body position during the acute phase of stroke. The position of the patient with and the head of bed should be individualized with respect to the risk of elevated intracranial pressure in some condition, aspiration, and in the presence of the combined cardiopulmonary disease. Data are limited and no randomized trial has been addressed this issue. Fever also can increase the size and volume of infarction if the patient presents with fever. Hyperthermia may act via several mechanisms to worsen cerebral ischemia, enhance release of neurotransmitter, exaggerated oxygen radical production, and more extensive blood-brain barrier breakdown, and increase the number of potentially damaged ischemic depolarized in the vocal ischemic penumbra. Treatment, treat the source of fever should be investigated and treated, and antibiotics should be used to lower the temperature in febrile patients with acute stroke. Maintaining normothermia for at least the first several days after an acute stroke is important. In a systemic review and meta-analysis of 5 small randomized controlled trial with a total of 293 patients, there was no benefit from pharmacological temperature reduction for acute stroke. So induced hypothermia is not currently recommended for patients with ischemic stroke. Blood pressure monitoring treatment is very important also in the acute ischemic stroke, especially for those patients who candidate for IV TBA, and because the risk of bleeding is high with high blood pressure. Acute ischemic stroke is different from the approach in acute hemorrhagic stroke, differ between the blood pressure management in the acute ischemic stroke and the chronic phases of stroke. The perfusion pressure distal to the obstructed vessels is low, so the distal vessels are dilated, impair cerebral autoregulation. Cerebral autoregulation is ability of cerebral blood flow to vasodilate or vasoconstrict with a certain limit. Then it loses its function. So blood flow in these dilated vessels depend upon the systemic blood pressure. So the arterial blood pressure is usually elevated in the patient with acute ischemic stroke due to chronic hypertension, acute sympathetic response, and other stroke-mediated mechanisms. Acute elevation of the blood pressure is necessary to maintain blood-brain perfusion in borderline ischemic stroke, and also to increase the blood flow through the collaterals, which these vessels are blood pressure dependent. If you reduce blood pressure, so this is the collateral will not work. The patient has more ischemia. Patients with acute ischemic stroke who are not treated with thrombolytic therapy, usually we keep blood pressure more than 220 over 110 20. Achieve active ischemic coronary disease, heart failure, aortic dissection, hypertension, encephalopathy, acute renal failure, or preeclampsia. We have to unless this patient has these disease. Lowering of blood pressure by approximately 15% during the first 24 hours post stroke. Patients with acute ischemic stroke who are receiving thrombolytic therapy, antihypertensive medication is recommended if systolic blood pressure is more than 185 over 110. Current guidelines note that vasopressor may be used to improve the cerebral blood flow in a rare condition when systemic hypotension is producing neurological impairment. With those with neurological and with close neurologic and cardiac monitoring. So sometimes if the patient has hypotension, also increase the size and volume of ischemic stroke. The choice of antihypertensive in acute phase of stroke, there is no clear evidence to support the use of any specific antihypertensive agent to achieve the recommended blood pressure goal. Reversible and titrable intravenous agents are the best medication for price blood pressure lowering. There is agreement or consistent guidelines suggested that intravenous labetalol and nicardipine as a first-line antihypertensive agent allow rapid and safe titration to the goal blood pressure is very important. Active therapy for eligible patients with acute ischemic stroke, intravenous Antiplatelet is the first line of therapy, provided that the treatment is initiated within 4 hours and 30 minutes. Clearly define the symptom onset because the benefit of Antiplatelet is time dependent. If the patient receives IV TBA within 2 hours, differ from the patient who receive TBA within 3 hours. So because the thrombus, the aging of thrombus will affect the efficacy of the Antiplatelet. And sometimes if the patient have a wake-up stroke or his symptom onset unknown, we have another technique and another new imaging. It is critical to treat the patient quickly, and possible eligible patient with a large artery occlusion present within 6 hours of symptom onset should be received by thrombolytic therapy, mechanical endovascular thrombectomy, and but if after the CT which shows a large vessel occlusion. Because as you know, the TBA doesn't work in a large thrombus. More than 8 millimeter is difficult for TBA intravenous to work if given intravenously. We need a mechanical thrombectomy. Prompt reperfusion is most effective treatment for the patient with acute ischemic stroke. The principle of acute stroke therapy are to achieve recanalization of the occluded vessels, reperfusion of the ischemic tissue, and to minimize collateral, to optimize collateral flow and to avoid secondary brain injury. This is, I'd like to present this slide because sometimes I'm very keen for those patients who have a low NIH score and not receive TBA, and you didn't give them the chance to give TBA. Last week, I have one patient with only just aphasia. NIH score is 2. Patient can understand me, but she cannot toxo, she has a motor aphasia, NIH score maximum 2. No neurological, no limbs weakness. So I give her IV TBA. She's immediately recovered and discharged home with fluency, with normal speech. So this paper showed that 27% of those not given TBA because they are too good to treat die or were not discharged home because of neurological worsening. So remember, the chance of he develop a major stroke in the 24 hours. This is an indication candidate mechanical thrombectomy for those patients who's candidate for TBA for mechanical thrombectomy. The age more than 18 years. NIH score is more than 6 or equal to 6. Time of symptom 6. A good pre-stroke function stated. That means modifying Rankin scale. Yeah, you cannot take a patient for mechanical thrombectomy. He has a dementia or he is a bedridden. Aspect score more or equal to 6 on baseline CT scan. Presence of proximal intracranial occlusion, ICA, M1, M2 occlusion, or basilar artery occlusion. And stroke unit care, all the studies show that hospital who that has a specialized for the care of patient with all types of acute stroke. This is shows a better and excellent outcome compared with those hospital who they don't have dedicated stroke unit. The component of an acute stroke unit vary between center and country, but generally include a hospital ward with a dedicated telemetry beds that is continuously staffed by a team of physician, nurse, and other personnel, which include specialized in the stroke care, like physiotherapy, occupational therapy, and also swelling team, and also emphasize expertise in the vascular neurology and neurosurgery. Stroke unit care additional component including neuroimaging, CT scan, MRI, various type of angiography, ultrasound, transcranial Doppler, and also cardiac imaging, especially for those if we have a CT perfusion, MRI 24 hours, 7 days a week. This is important for those patients who have unknown stroke onset. Implementation of stroke protocol and disease performance measure may contribute to improve the outcome and decrease the risk of stroke-related complications. This is a monthly meeting or every 3-month meeting done by the committee who are dealing with a stroke, and they discuss the challenges or the problem that may interfere with the development of stroke care. Prevention of complication. We have a lot of complication. MI, heart failure, aspiration pneumonia is the most common. Urinary tract infection, DVT, pulmonary embolism, dehydration, malnutrition, pressure sores, and orthopedic complication and contracture. A lot of patients, if they are staying in the bed, sit in the bed for a long time, they may have developed deconditioning. Thank you so much for listening, and this is the end of my slide.
Thank you, Dr. Majid, for this comprehensive lecture. Actually, you cover everything for management of acute stroke. Especially, you focus on general antiseptic examination, swallowing, which is very important also in stroke management. All this to prevent complication. We have 5 minutes. A question for Dr. Majid if the audience want to ask Dr. Majid anything. Any question for Dr. Majid? Okay, so no question for Dr. Majid. Now we'll go for, we can go for Dr. Saeed Zahrani. And after that, if there is, if the audience want to ask something, we can collect also the question at the end of the lectures. So Dr. Saeed Zahrani will talk about the stroke code and stroke units. Welcome, Dr. Saeed.
Assalamu alaikum. Jazakum Allah bikhair. Good evening, everybody. So first of all, I would like to take this chance to salute and congratulate Saudi German Hospital for getting the GCI accreditation, and for Dr. Mustafa and his team for their intense effort, which is very well known since a few years in stroke care. My topic today will be on stroke unit and stroke code. And I think this first slide will explain most of the things. That stroke code, it's all about time. So we want to save more time for patients to be treated and recanalized. And as much as we save time, as much as we save brain. We always say that time is brain. And in a study, it shows that 2 million neurons died every minute best by the patients. And around 14 billion synapses each minute will die, and around 12 kilometers of myelinated fibers with each minute. And I used to say in each hour, the patient delayed in receiving recanalization or the treatment or thrombolysis, it's like losing myelinated fibers, like from if you travel from Taif to Riyadh, which is an 8-hour trip. So that would be an enough myelinated fiber to be lost before an immediate recanalization and immediate treatment should be started. So there are several studies to save that times, which is getting even to the patient's door, actually, by mobile stroke units. So that instead of waiting for the patients to arrive to the hospital and run the stroke code and the stroke system, actually more studies now showing the efficacy of mobile stroke units and going to the patient's door and the patient's home, doing a CT scan there, and deliver IV TBA through a telestroke network, and then transfer the patients to receive further care. That's all is to stress on the time to initiate stroke code. They used to say we need a door-to-needle time less than 60 minutes, but recently the recommendation is to be even less than 30 minutes. And as soon as we deliver IV TBA, as the benefits will be better. There are several models of doing activating stroke units, and one model is called the Helsinki model, where they achieve a median time of door-to-needle time of 20 minutes. That's need a strong collaboration between the EMS, emergency physician, as well as the stroke neurologist or the neurologist, in-house neurologist, to facilitate the rapid transfer from the brain notification. And I know that the General Authority of Red Crescent, they start to establish a Musaf electronic, which is an electronic system that will be installed in major hospitals in the emergency room. Is like a screen that will show a patient is in his route to the hospital, and there will be around an approximate time of arrival of around 5 minutes or 10 minutes. this patient has these symptoms, and the team will be waiting for the patients, and instead of the patient will be waiting in the triage or in the emergency room for the physicians to come to him. And then even pre-arrival, there will be a registration and request and establishing an electronic records. The IV line will be inserted before arriving to the hospital. And once arrival in the emergency room, they already know about the patient's conditions. He will be immediately, the route of entry will be actually the CT scan. So it will go straight to the CT scan, and the TBA will be there in the CT scan room. So it will be administered through the stroke kit. The bolus will be administered after the initial CT. This is all is to save time, which is seen in several studies, that if we treat patients in less than 90 minutes, we would the number needed to treat would be 4 to 5. From up to 3 hours, the number needed to treat is 9. From 3 hours and to 4.5 hours, the number needed to treat will be 14. So the time, as the time curve, the time goes down, the benefit will be less and less and less, and then it will reach no benefits if there is more than 4.5 hours, unless we have, of course, an advanced neuroimaging like CT perfusion, which can extend the time window up to 9 hours now. This is our data from King Fahd Hospital, which shows actually those patients, they receive TBA. But the blue ones, they receive the TBA prior to establishing a stroke code, and orange one, they receive the TBA after the establishing stroke code. And this is the modified Rankin scale at 3 months. Actually, we were surprised that even the functional outcome would be better. Those patients, they receive TBA, all of them. But those, they receive TBA post stroke code. It will result in good functional outcome in 3 months, as well as the length of stay will be even lower in those patients whom receive TBA and post stroke code. This is explain why the stroke code is very important in reducing the door to needle time. And once you reduce the door to needle time, you would have a good functional outcome. You would receive even more patients. And actually, in some other centers, we established a stroke code. And after establishing a stroke code, we start to see patients. In Najran Hospital, we established stroke code there. And after, actually, in the last year, there was no stroke code. There was no TBA. After establishing a TBA, just in one month, there were more than 10 stroke code. 5 patients, they received TBA. 5 patients, they were actually out of the time, or they are stroke mimickers. So you would receive even more patients. More patients would be treated early. You would have a good outcome. You would reduce the length of stay for patients once they have the good outcome. This is most of the lectures will be based on this. So in order to shorten the time from the door to needle time, you would have a simultaneous process that's done together. This is not a sequence process. So you don't wait to maintain an ABC, well, actually you just observe ABC, and at the same time you take history, or you do the NIH stroke scale. Other members of the team will do the vital sign and blood glucose by glucometers. The nurses will insert 2 large IV lines, and a blood sample will be withdrawn and sent for CBC, creatinine, and electrolyte, or if you have in your emergency room a toolkit to do the point of care creatinine or BT and INR, it would be helpful in helping you in decision making after you receive the patient from the CT scan. Although you don't need to wait for the result of BT or platelets count if you don't have a bleeding disorder or a bleeding diathesis. And then you obtain an ECG, and all of this you order your stroke protocol. And during this process, it shouldn't take more than 5 to 10 minutes. Or you do some of your history taking, confirming the onset time, taking more detailed history inclusions and exclusion criteria, ask him if there is any history of fall down, any history of bleeding. This should happens during the movement or during the transfer of patients en route to the CT scan, or during transition of the patients from the AR stretchers to the CT tables. You should not delay the process in order to take history, or you do your NIH stroke scale, or you perform your functions. This should be done en route, and then the CT scan, it should be obtained early and interpreted as soon as possible. And if they have a good aspect, they don't have an established stroke, you would start thrombolysis. And your stroke protocol, sometimes if you are a stroke unit with the endovascular capability, you may include CT and CT angio immediately in order to confirm large vessel occlusions. Or if you are a small hospital, you can do CT, give IV TPA. If there is if the NIH is more than 10, you would request CT angio to confirm and then transfer your patients. Once the patient's back to the emergency room, you would start the IV thrombolysis infusion, and then in the critical emergency room, the whole process will be there in terms of observations, IV infusions, observations of the blood pressures, neurovital signs in the first few hours, and then admitting the patients to the ICU, or if you have a stroke unit with close monitoring bed, that you can admit patients to the stroke unit, and you follow up next step. So the whole process, it should be fast, should be simultaneous, and it shouldn't take more time. And you have to repeat this, improve it next time, see where is the point where you lost the time, negotiate with the emergency room, negotiate with the CT technician, because if you receive the patient, you don't want to wait for the CT technician to respond to your phone. While actually, once you trigger the stroke code, the CT technicians, he should leave everything and wait for the stroke patients without calling him or asking him to prepare the bed. He should stop any actions, any routine work, wait for the stroke patients to arrive, and then you do the CT imaging stroke protocol. There are specific things for the emergency room or triage persons to observe, like the initial scan be fast, so they balance eyes deviation or eye or vision loss, visual field loss, facial droop, eye arm weakness, or speech difficulty, and then they should respect the time. These are the symptoms. Once it's observed, the triage person, either a triage nurse or the triage doctors or paramedics, if the patient came as walk-in, should trigger the stroke code as soon as getting those patients, even if they are mild. So you need to enforce the idea that even if the symptoms is mild, you shouldn't make patients wait. Activate the stroke code, and then once it's evaluated later on with the stroke physicians or the neurologist, if it is not a true stroke or a stroke mimickers, or the time is more than 4.5 hours or 6 hours in those with the thrombectomy centers, or 24 hours in those centers where the CT perfusion is available, then the stroke code will be halted. If any one of those signs is positive, the probability of a stroke is 72%. There will be, of course, there will be a stroke mimics. Stroke mimics in some centers, it's up to 25% of stroke code are stroke mimickers or stroke or false stroke codes. The general overall principle is if you have a negative symptom, so loss of sensory or loss of motor power, this is a stroke. If it is a positive symptoms like tingling sensations or that's a positive symptoms, that's most likely is a stroke mimics. Don't categorize patient as stroke mimics unless you are 100% sure. Did I thrombolize stroke mimics before? Yes, I thrombolize stroke mimics before. Many stroke neurologists even, they thrombolize stroke mimics where they discover that next day or when they took a detailed history or physical examination that those actually are other neurological disease. In the era of CT perfusion or CT angio, probably the stroke mimics is would be low and low once you have the arterial occlusions. That's of course not a stroke mimics. Once there is a stroke, less perfusion, that's of course not a stroke mimics. So seizures with Todd's paralysis, it could mimic stroke patients, brain tumors, demyelinating disorder, acute demyelinating disease, myasthenia gravis, where some of their presentations will be stroke mimics, Bell's palsy, and complicated migraines, other infectious disease, metabolic disease. All of these may mimic stroke patients, so you need to be careful. Thrombolizing stroke mimics actually is safe, is even less than 1% rates of overall hemorrhage, either plain or systematic hemorrhage. So unless you are sure that this is a stroke mimics, consider him for as a stroke. Do your investigations. If you are still suspecting stroke mimics, do CT angio, do CT perfusion to evaluate the patients. So the whole ideas on stroke code is to save time, to facilitate early recognition, early stabilization, early evaluation by specialized services, rather than the patients waiting in the triage room, waiting for the emergency room to see him, and then he would request the CT. If the CT there is no hemorrhage, he would request, then he would call the on-call neurology, where it will take time. This process, we noticed that it will take at least 1 hour or 1.5 hours before calling the on-call a neurologist to evaluate the patients. My next, the half of my next topic will be on stroke units. So the stroke unit actually is not recent things, and it is not a tertiary care. Stroke unit is a primary care. That's each hospital should have a stroke unit. And one thing is that we are here in Saudi, either as a Ministry of Health and in many other institutions, we still had that in our mind that stroke unit is a tertiary care and it's present only in the higher centers. While in fact that each stroke patients should be admitted in stroke unit, regardless what is the size of the stroke unit, regardless what is there to take care of the patients in the stroke units. So the stroke unit is we always say it is an organized stroke service. So it's a dedicated stroke bed with multidisciplinary team that will provide 24 hours care for acute stroke patients. The multidisciplinary team is we said that a medical team, including neurologists, internal medicine, the physiatrist, the neurosurgeon, psychiatrist. These are the medical team. And then the nursing team, which is even very important in stroke care, because they need to know the protocols. They need to learn how to move the patients, how to feed the patients, when to feed the patients, how to take care of bed sores, of Foley catheter, which is actually very important. Physiotherapy and occupational therapy, when they start mobilizing the patients out of the bed, which is it should be as soon as after 24 hours from the stroke symptoms. Speech and language therapy, evaluations of the swallowing, the evaluation of the types of food that should be started for the patients. Social worker to facilitate discharge dispositions as soon as the patient admitted. So this, the umbrella of the stroke unit, will help organizing the stroke service and will help building the team towards better care for the stroke patient. As I said, it's not a new concept. It was started in 1950. There were several randomized trials and several trials comparing stroke team versus stroke units. So admitting stroke patient in different wards of the hospital, and the stroke team will take care rather than stroke unit. Those studies shows that stroke unit is actually better, which is I would talk about in a few slides. So the stroke care is started even by primary stroke prevention, and then we would say the EMS care, pre-hospital notification, and the emergency room with the stroke code that we go through it, early monitoring and admissions to ICU and to this intensive stroke units. The earlier admissions, which is the stroke unit admission, where all the stroke workup is there, all the stroke planning is there, the stroke education, the complication prevention, the workup, starting the treatment, finalizing the dispositions of the patients, and then the rehabilitation and the community home. So the stroke unit is in the, there are several types of stroke units, some of them as integrated stroke unit, where early stroke care and then rehabilitation care, or hyperacute stroke care and then acute stroke care, or rehabilitation stroke unit. All of this is it will comprise stroke unit care. There are several studies that this is a Cochrane review of more than 28 trials of 5,000 patients. It shows that more organized care was consistently associated with an improved outcome. Stroke unit care, it showed that reduction in odds of death in the final outcome with the significant p-value. The odds of death or institutional care was even better if the patients get admitted into a stroke unit. The odds of death even better. So all odds of death and dependency or institutionalized care is less in patients who only just get admitted in stroke units. This admission or stroke unit admission or the stroke unit outcome, regardless of their stroke severity, sex, age, stroke types, either they receive TBA or not, they would have a better outcome once they get admitted into stroke units. If you establish a stroke unit, it would not increase the length of stay. Actually, it would have a decrease in fatality care earlier on. It would have a decrease in the odds of death among all cause of death or all cause of morbidity. They would benefit. The admission to a stroke unit is even better than admissions to a regular bed. In terms of in-hospital fatality rate, which is by its own, it would be enough to convince policymaker and hospital administrator to establish stroke units. If you have a stroke unit, the process of care or the adherence to process of care, the stroke protocol, the initiation of feeding, the evaluation of swallowing, the early mobilization, prevention of bed sores, it's even the adherence is around 75% comparing the stroke team care comparing to conventional care. There are even patients who will be more alive at discharge if he get admitted to stroke units. And as I mentioned, that in the stroke patients, regardless of age, the benefits and the outcome is better. There will be an early mobilization and social interaction in stroke units. The physiotherapy team, they are there. They know how to take care. They already, instead of physiotherapists in the same ward taking care of stroke patients, orthopedic patients, heart failure patients, they would focus on stroke patients, so they would know the needs. They will attend more workshops on how to take care of the patients. And then that social interaction or that mobilizations out of the bed will get the patients engaged with the surrounding, engaged with his relatives once they are around him. The stroke unit actually even was if the patients get admitted to a stroke unit, he will get more attentions to his medical needs. So the complication rate will be lower, as we know that if we get attention to those needs, we are going to prevent it early on. If we stick to a protocol, we are going to follow the protocol to prevent those complications, so including DVT, respiratory, aspiration pneumonia, the UTI, which will result in good outcome, result in patients transfer early to rehabilitations and decrease mortality. So as I mentioned early, each stroke patients deserve to be admitted to a stroke unit, regardless what is the type of stroke units. So that stroke unit either is a comprehensive stroke unit in a comprehensive academic medical centers or tertiary care facility, or primary stroke center, or the more common that should be established, which is an acute stroke ready hospital in a small community and rural hospitals. Those stroke units, it needs to be combined in a network. So the patient in primary stroke center should be, at least if they need more comprehensive care, should be connected to comprehensive stroke centers. Those in rural or small community hospital with acute stroke ready hospital should be connected to a primary stroke center or comprehensive stroke centers. So there are some difference in terms of distinctions between acute stroke ready hospital, primary stroke centers, and comprehensive stroke centers. All of them, they should have a stroke team available 24/7. Those in the acute stroke ready hospital or primary stroke centers, they may need and help from telestroke care to provide a 24/7 service, either as a sole telestroke or as a PRN telestroke help. The neurosurgery, it shouldn't be a major issues in acute stroke center or primary stroke center, but they need to have a written protocol for transfer a nearby hospital to transfer patients once they needed a neurosurgical attention. Endovascular thrombectomy, it should be available in comprehensive stroke centers. There are another category where they call it primary stroke center with endovascular capability, where some primary stroke center, they develop an endovascular capability to conduct neurointervention, which is shown to be of benefits. Rehab as well, it's necessary, and diagnostic need. You need only CT images in acute stroke at the hospital, but you need more advanced imaging in primary stroke centers and even more advanced in comprehensive stroke centers. So from 30 beds to 100 beds, these are acute stroke at the hospital. From 100 beds to 400 beds should be primary stroke center. More than 400 beds is a comprehensive stroke centers. So how to get what you want? How to get the stroke unit? You need to speak the language of people that you are talking to them. So for the community leaders, you would engage them into showing them that the impact of a stroke unit on public health, that you reduce the community stroke burden, and you show them that the incidence of stroke is rising. Like in our population, we are a younger population, and the incidence of stroke is rising. Unfortunately, the incidence of vascular risk factor is strikingly higher. And those populations, if they are getting more, we are an age, we get more elderly as we have an expected longer lifespan, the stroke will be increased. And if we establish a good system from now, we are going to save much on the community level. The hospital administrations, you would say, on their return of investment by either increasing their revenue, you decrease the length of stay. If you establish stroke unit, you will mobilize patients fast, you will treat patients fast, you would shift them to rehabilitations. So in private sectors, you would speak on return of investments. In governmental hospitals, you would speak on cost effectiveness and reducing the cost on the healthcare system. The medical doctors, you would show them that the stroke would increase the access to healthcare. It will facilitate their care. So instead of taking care of patient that is admitted in an orthopedic ward or in surgical wards or in a medical ward, your patient will be in a specific unit that you would focus your care on them, and that will ensure more safety. The nurses will pick up cases, they know how to deal with them, they know how to take care of them. The nursing, you would show them the quality of care, you would show them that already you know those cases, already you know how to handle stroke patients. It would say that less hospital stay, the equipment that is needed for patient care, it would be there and it would be helpful to them. So that once you establish the need, you start to plan your stroke service, incorporate your stroke unit, and you do your time schedule, get your stakeholders and stake either nurses, neurosurgeon, your neurologist, interventionalist, neuroradiologist, get them to be aligned with you in terms of providing the care. And I know that you would face resistance. I know I faced resistance. We established a stroke unit, and we faced resistance once the COVID-19 pandemic appears. The stroke unit is closed. We are trying to reopen it and reestablish the services. The big issue is that it is still not in the map of the Ministry of Health to establish stroke unit in each hospital, but soon it would be there. Many hospital directors would say, why should I put budget in stroke unit where I need it for cardiovascular care, I need it for other intensive care units nowadays, which is in the terms of COVID pandemic is there. Those are resistance that you would face it when establishing a stroke system of care or stroke unit. But hopefully, with convincing them that this is a cost, this will be a cost reduction in the hospital. Even if you pay more money to organize the service, or you get some of members of the stroke team, eventually the cost will be reduced at the long term. If it is not reduced in the hospital, it will be reduced on the overall healthcare or overall burden on the society. This is that to show you, once the stroke unit or stroke centers established in the US, they start to have more utilizations of IVTPA, more administrative support once they have that system in care. So in summary, an organized inpatient stroke unit care is most powerfully applicable stroke intervention, that you can do it for those who came early, those who came late, minor stroke, severe stroke. All patients will benefit from the stroke unit. If you look at it from a large scale point of view, the stroke unit is more powerful intervention than thrombolysis or thrombectomy. The basic models of stroke unit care is very well described. You can get it easily online. You can easily implement the service, easily train people. There are some initiatives to help establishing the stroke care. With this, I would end my presentation, and thank you again for giving me this opportunity. Thank you very much.
Thank you, Dr. Saeed, for this organized and very excellent lecture. You give us the idea about the importance of the importance of time in treatment acute stroke, and how to fasten the process of management of stroke, and the importance of the stroke unit. If there is any question, we'll ask Dr. Saeed. There is a question from Dr. Iyad. Do we have an example of a stroke unit?
Yes, so we have an example of a stroke unit that is established, but as I mentioned earlier, it's still in the concept of the policy makers and the higher authority that stroke unit is a tertiary care. In terms of establishing it in the Ministry of Health or the General Hospital, we try to do it in King Fahd Hospital. We initiate the stroke unit. We start the care of stroke patients in a stroke unit, but then it stopped in the COVID pandemic. In Al Medina, Dr. Jani established a large stroke unit where he admitted all patients into the stroke unit. You need to start doing it, and then you would convince your authority. I would recommend not to request many things from the administrations. So yeah, don't be make things very complicated. Just told them I would need 5 or 3 beds or 5 beds near to each other, and then that's what we call it stroke units. And then you would request monitor, you would put your stroke protocols, you would implement, you would request physiotherapy to be part of your team, you will build your multidisciplinary team. With time, you would have your stroke unit with you.
Another question about the upper limit of blood glucose during acute stroke management.
I think this should be for Dr. Majid, but for me, there is no upper limits for blood sugar management. But if you are convinced that this higher blood sugar is the cause of the stroke symptoms, then you need to treat it. If you have proven that this is an artery occlusion, this is a very clear stroke. So regardless of the blood sugar, you need to treat patients with thrombolysis. But you need to yearly control of blood sugar. Tight control with IV insulin is not recommended. It would even cause even more harmful. But yeah, you would consider thrombolizing patients regardless of the higher blood sugar. Lower blood sugar on the other side, it may be the sole responsible for the patient symptoms. So first treat the hypoglycemia, then wait for the patient, see if he responds or not. If he responds, then the symptoms is secondary to hypoglycemia. It may be overimposed stroke, so you have a stroke patients, and then you have hypoglycemia. CT angio or CT, especially CT angio. If you have an occlusion, that's a stroke, regardless is hypoglycemic or hyperglycemic. You need to open the artery and recanalize the blood vessels. I don't know if Dr. Majid wants to add on this, or Prof. Helmut, if he's with us.
Dr. Majid, do you like to comment?
I don't have to add anything relevant.
Thank you, Dr. Mustafa. Said said more enough.
Okay. Another question regarding admission in ICU after intravenous TPA. Patient who receive intravenous TPA can be admitted to an open ICU service with no intensivist in a secondary hospital.
Yes. Yeah. So you can admit stroke patients even to a stroke unit. You don't need to admit thrombolized patients into an intensive care unit. You just need to keep him in the emergency room for the first 3 hours. You have to train your nurses to do neuro vitals. So in the first hours, like every 15 minutes, then every 30 minutes, then every 1 hour over the first 24 hours. At any time there was a deterioration in neurological state, even in the first 24 hours, repeat your imaging, rule out intracerebral hemorrhage or worsening of stroke patients. So you need to admit patient into a monitored bed, not necessarily ICU bed.
Yeah, so if the patient is not stable, or the patient, the general condition is not good, it's better to admit him in ICU. And once the patient is stabilized, you transfer him to a stroke unit. Agree,
completely agree.
Is there any patient stroke with COVID-19 symptoms? And are there the same treatment with those patients stroke without COVID-19?
Yeah, so there are several evidence that showed that COVID-19 would cause hypercoagulable state, and we observed this, that COVID-19, they have stroke. There are several studies that showed the association of stroke incidence in COVID-19 patients. I would treat them the same if they are presented early. I would thrombolize them. If they have large vessel occlusions, I would do thrombectomy. There are published in the Saudi Stroke Society. They published papers on COVID-19 and stroke patients with the specific protocol and for the COVID-19 and stroke patients. It's in the Neuroscience journal.
Yeah. This is a protected protocol. Yeah. Protected protocol for treatment of stroke patients with COVID. Another question about the incidence of cerebral edema as a cerebral reperfusion as a complication of type A.
So of course the cerebral edema is actually more with if you don't recanalize patients. After recanalizations, you would have a more increased risk of intracerebral hemorrhage. The reperfusion edema or the hyperperfusions is there, and it's you should monitor it earlier on. But that's if you recanalize patients early.
Thank you, Dr. Saeed. We are happy to be with us today. Now we'll have the last lecture for Professor Hilmus about update on intravenous thrombolysis and secondary prevention. Okay, Professor, we are ready to hear from you.
Thank you, Dr. Mustafa. Thanks for inviting me again to this solid German stroke symposium, online symposium. And also thank you for giving me my topic update on IV thrombolysis and secondary prevention. I split this in two parts. First, thrombolysis, after that, secondary prevention. But first, let me say that what I'm telling you now is absolutely that which comes after doing the groundwork. And this has been addressed by Dr. Majid and Dr. Saeed. And the groundwork, of course, is having a stroke unit and building a service like you described it, even without using medications such as IV thrombolysis or recanalization or whatever you may think of. Just caring for the patients in the stroke unit saves 1 in 10 lives and lets 1 patient in 10 live independently instead of being dependent. So because the people working there know the complications, know to prevent the complications, and this comes before thrombolysis, and everything which comes that is on top of a stroke service as described by the speakers before me. Well, to start, one other thing. I saw that we have an attendance of over 1,000 people listening and watching. This is unbelievable. I assume that not all of you are stroke specialists, can't be. Maybe many of you are non-neurologists, maybe medical students. I will try to address all of you, which is probably not easy because some things are maybe too simple for some of you and others may be too complicated for some of you, but I'll try to please you all. And I start with an update on IV thrombolysis 2021. As mentioned by Dr. Saeed, this treatment is around now for 25 years. We know it well. It has a number needed to treat of 10. Again, on top of the stroke unit care, you save another 1 in 10 patients by thrombolysing him or her. And of course, the effect is the strongest in the first hour, as you saw, and it weakens a little bit after the first hour. I'll show you some data on that in a moment. Also, let me say that none of the topics I'm addressing today, none of the drugs, medications I address, none of the companies producing them or developing them has paid me a honorarium ever. So don't be afraid of marketing by myself. I will not do that. Now, what will I address in the first part of my talk on IV thrombolysis? It's not easy to have regular updates on IV thrombolysis because it's an almost traditional treatment now, but there are some, and there are some recent news which I will address in what I'm telling you. IV thrombolysis in high age, above 80. IV thrombolysis beyond the 4-hour window or after stroke of unknown onset. Thrombolysis in mild stroke, whatever you may think is a mild stroke, let's say NIHSS below 9. Many of them consider that to be a mild stroke. What about the reduced TPA dose? I know that many of you love that. I'll tell you something about it. And new thrombolytics like tenecteplase, I will also address that. I will include in my talk the recent updates that have been made concerning thrombolysis and secondary prevention in the Canadian guidelines, in the American guidelines, in the European Stroke Organization guidelines, in the Australian guidelines, and last but not least, in the new German guidelines on acute stroke treatment and secondary stroke prevention. So you will receive news from the last 2 years. I will also show many papers, but all of them are from the last 2 years and attracted my particular attention. Now, you have seen a graph similar to that before, but this is from a paper published in 2020 by colleagues shown above, pioneers of RTPA treatment among them. And this is a systematic review of 7 randomized controlled trials of a full dose, let me say, alteplase RTPA treatment in 6,000 patients who had been randomized into these 7 studies. I will not go into the studies in detail, but show you this result of the systematic review. This is the relation between the odds ratio of a good outcome, in this case 2, 1 hour, if you start to treat the patient with IV TPA, 1 hour after onset of symptoms, you have an odds ratio of 2 that he will end up with a good outcome, in this case defined as a modified Rankin scale score of 0 to 1. Not even a neurologist may notice a deficit in these patients. So they have a very good outcome living independently and without relevant problems. So this is the odds ratio is 2 after 1 hour. It's even better in the first and the golden hour where you only have a number needed to treat of 4. But it then levels off, as you all know. This is nothing new. That's not an update. This is well known. And the 95% confidence interval, which you see here in the dashed line, touches the 1.0 odds ratio baseline at a time point almost at 5.0 hours. So there's a little bit, maybe a little bit more than 4.5, but of course, the approval of the drug is 4.5 in most countries. Some of them still 3.0, which is outdated, but in most countries it's 4.5. But you see, there is a little bit time even beyond that where you can expect some effect of the drug. So this is the relation between time since onset of the stroke symptom and the effect of our TPA treatment. This is nothing new, but the same paper had other interesting data which address some of the other questions I mentioned before, because in these 7 RCTs, in these 7 studies, there were also patients different from the patients in the very first trials, which were very old and which had only mild strokes. And I will show you that in a minute. Let me mention, different from Saudi Arabia, in Germany and in North America, every 3rd stroke patient is above 80 years old. So this is a big topic. And at 20 to 25% of the stroke patients we see come with an unknown time of symptom onset. So that's a big thing I'm going to address. So what about age? This is the same paper as mentioned, same systematic review. Now in this case, odds ratio of a good outcome shown here compared to age. And you see that the line is almost horizontal. The only thing that happens is that beyond the age of 90, because fewer and fewer patients were included in the studies at this age, the confidence interval crosses the 1.0 baseline. So you can be quite confident based on this huge database of randomized controlled trials. That's not registry, it's randomized controlled studies, that there's no real reason to limit RTPA treatment to patients below 80. I would say you can easily treat them up to 90. We sometimes even treat patients older than that. So no limit regarding high age. Of course, the very old patients have a worse stroke outcome, but the relative effect, the relative effect of treatment is similarly high as in the younger patients. Now, stroke severity, again, There are people saying that below an NIH stroke scale score of 9, they don't give TPA. This is the same study, same number of cases, full dose TPA treatment in 7 randomized controlled trials. You see the good outcome odds ratio runs here, and the 95%, the lower border of the 95% confidence interval touches the baseline at an NIH scale score of 4. And that's what we also do. So we treat them from NIH 4 and above with IV TPA, 3 and below. They're usually not, but there also are exclusions to that. Because you saw the NIH stroke scale composition before, and you know that a patient with a severe aphasia, isolated aphasia due to ischemia, may only end up with an NIH stroke scale score of 2, or a patient with a complete hemianopia, also only a stroke scale score of 2. So we sometimes treat them if the patient is otherwise healthy and the deficit is of high relevance to his, let's say, profession, his work that he's doing. So also here, the NIH is not really the only criterion the treatment should follow. Also, the relevance of the deficit for the individual is another criterion we sometimes apply. So don't be shy to use TPA also in the so-called mild strokes, NIH 4 and above. Now, what about the unknown onset of the stroke, or the time window of 4.5 to 9 hours? It was mentioned by the speakers before. You have, in this case, you don't have the clock. If you don't know the time of onset, or if it's between 4.5 and 9, you cannot simply use the clock. You need imaging, imaging guided TPA treatment. One way is shown up here, probably known to all stroke specialists today, the DWI flare mismatch. This is not really a core penumbra mismatch. It's a, let's say, surrogate of the clock, because if an infarction is visible on DWI but not visible on the flare, you can be very certain that this is a stroke that has started below 4.5 hours ago. So shown here in this case, large DWI lesion of a cortico-subcortical embolic looking type, negative DWI scan. In this case, you can be certain that the onset is below 4.5 hours. We would treat the patients in accordance with all guidelines, even not knowing the precise onset of his symptoms. Same shown here for a subcortical stroke, flare negative, DWI positive, DWI flare mismatch, wake up trial, published a couple of years ago in the New England Journal. That's one way of solving the problem of the unknown time of onset. The other way is shown down here, also mentioned before. It's the core penumbra CT or MRI based imaging, where you image the established core, more or less, of the infarct, and you measure the tissue at risk of becoming an infarct in the next, let's say, 24 hours. And if the mismatch is large enough, I won't go into details, but if there is a relevant mismatch of 25% or more, then we usually treat these patients with IV TPA, and of course with mechanical recanalization as well, if applicable, if they have a large vessel occlusion. But in this case, I'm talking about IV TPA. We would, and all guidelines recommend that between 4.5 hours and 9 hours, you can use and should use IV TPA if you are able to establish a mismatch between established infarct core and endangered surrounding brain tissue. Next, shows you a very recent 2020 published paper giving doing a systematic review of the 3 trials that I have addressed in the last slide. That's the Wake Up trial, that's the DWI mismatch trial, and the Extend and the ECAS4 trials, 2 other trials using core penumbra mismatch imaging based on CT or MRI, usually using the RAPID software. The ECAS4 trial was small. It was terminated early because of bad recruitment. That was immediately after the recanalization came out. So 2015, the 4-5 studies. So it had bad recruitment, was stopped early, but fortunately another trial with a similar, let's say, design was finished successfully. It's the Extend trial published in the New England Journal, Greg Albers and co-workers. And if you do a systematic review or meta-analysis over these 3 trials addressing the problem of unknown time of onset stroke, you see that treating these patients on a randomized control basis with IV thrombolysis gives a clearly better result than to treat them with placebo. So based on mismatch imaging of the one or the other kind, you can use IV TPA in these patients and be similarly effective as in the ones where you know the exact time of onset. So this is my summary slide of the IV TPA part of my talk. First is acute ischemic stroke of unknown onset. Treat if you have a DWI flare mismatch in MRI. If the patient is between 4.5 and 9 hours, including those with a wake-up stroke, you can treat them if you see a core penumbra mismatch with either of the 2 technologies we have, usually software-based. You can calculate the mismatch volumes and ratios. This is the message for the unknown onset and delayed time window cases. Don't be shy, treat them. High age, there's no evidence suggesting that the effect diminishes above 80 years. We treat all of them unless there are other arguments arguing against, of course. Mild stroke, this starts with NIH-4, and TPA is effective even at these low NIH scale scores. And remember, even a complete hemianopia or a severe aphasia may deserve TPA, even though the NIH stroke scale score may be only 2 or 3 if the deficit is relevant for the person. Now, I didn't go into the details of these studies, but I promised to say something about the one alternative we have to alteplase, that's tenecteplase, very promising, much simpler than alteplase because you give only 1 single shot. And many people continue asking me, why don't we give that more frequently? One problem is that in Germany, we don't have it. It's not on the market here. I don't know whether you have it. It's maybe interesting for you to know that despite having it, the Canadian, some European, and the new German guidelines of 2021 do not actively recommend tenecteplase instead of alteplase because the number of patients treated is still much smaller than those treated with alteplase. And the other thing is that the studies are very different. There are different doses that have been used in the studies. One big study, successful study, used it only before mechanical thrombectomy, so that may somehow bias the result. So the overall result is that it's probably non-inferior, judging from the data we have, but it's not actively recommended by most of the large international guidelines that we read. The next thing, what about the reduced dose? I know many people in Asia at least, but also in the Arabian world are probably very fond of giving low dose. But keep in mind that it has not convincingly been shown to be non-inferior. It's difficult statistics, but that's why still the Canadian, Australian, and new German guidelines, all recent guideline updates, still do not recommend the reduced dose because the data are much weaker. You should have good reasons for using the reduced dose, such as pre-treatment with anti-thrombotic medications or other reasons, small body weight or whatever. So that was what I had to say about IV thrombolysis. I'll continue with secondary prevention. This part of my talk is a little bit longer than the one on IVT, and also includes the recent updates on this eternal issue of secondary stroke prevention, starting with aspirin a long time ago. Has recent updates from the German stroke guidelines, from the European Stroke Organization guidelines, and the very recent American Heart Association guidelines published recently in stroke. So I will include the major updates on news from these guidelines into what I'm telling you now. What am I going to address? We have a new LDL target in secondary stroke prevention. I'll discuss that in a moment. We have the eternal topic of antiplatelet drugs, which can be given, of course, a single treatment or double antiplatelet treatment. I'll address that also. We have the first trials, not randomized controlled head-to-head, but registry data of large numbers of patients being treated with direct oral anticoagulants after cardioembolic stroke and atrial fibrillation, and these data allow some judgments on the relative of which of the three is the best one and which maybe not as good. I'll show you that. I'll do a short excursion into clinical neurology. I hope there are many clinical neurologists among you, of what we consider a TIA and what we don't. That's a difficult thing. I'll come back to that. And if I have time at the end, I can also mention a few things which may be of interest in the upcoming years. So this is the first, the LDL target. That was a big trial, the Treat Stroke to Target trial, published in the New England Journal last year. The patients had to have a minor stroke, NIH 4 or less, or a TIA, and at least some evidence of atherosclerosis, meaning coronary heart disease, or some atherosclerotic changes in vascular imaging, ultrasound or CT, MRA. So if they had a neurological event, mild neurological event, plus evidence of atherosclerosis, they were randomized into two arms. One is the traditional one, treating or lowering the LDL to a value around 100 milligram per deciliter with a statin, of course. The statin in this case was left, the choice of the statin was left to the physicians treating these patients. The main thing was the target, which was 100 in this case. And you see that it was well reached in the higher target group of a 9-year follow-up. So very long follow-up with very stable LDL around 100 values. And the other randomized group was the lower target group, where the target was 70 or less milligram per deciliter. And if the statin was not enough, it was allowed to use ezetimibe in addition to the statin, which was the case in 33% of the lower target group. So what came out of this? It was a composite endpoint, myocardial infarction, stroke, or any vascular intervention, cardiac or other cerebral or peripheral. And the combined endpoint after 8 years clearly showed a better outcome of, let's say, 5%, an absolute 5% less endpoints in the lower target group, meaning 70 milligram per deciliter target group, which made another thing that I wanted to mention. The previous suspicion that aggressive statin treatment may increase the likelihood of intracerebral hemorrhage or may result in a higher incidence of diabetes mellitus was not true, not significant difference between both arms, resulting in the new guidelines in the USA and in Germany in patients with ischemic stroke, and you can add and TIA and any evidence of atherosclerosis. LDL reduction below 70 milligram per deciliter is recommended. If you don't reach that goal, a reduction by more than 50% of the pre-therapeutic level can be targeted as an alternative. So that's the LDL goal in the new updated guidelines. It's, let's say, a cardiological one. So we have also here, following TPA, following thrombectomy, following other things, we are always 10 years behind the cardiologists and now also have their LDL goal, which is very low. So many of you may sometimes wonder whether it's still, aspirin is still not only the cheapest, but also the best for our patients in stroke prevention. And there was an eternal topic, aspirin, but there was an interesting Lancet paper on more than 40,000 patients, of course, a systematic review of previous studies, addressing the issue of aspirin is inferior or superior to one of the P2Y12 inhibitors. That's ticlopidin, no longer on the market, clopidogrel, well known to all of you, and the more recent one, the en vogue thing, ticagrelor. So these three drugs, platelet inhibitors, are P2Y12 inhibitors. And this huge Lancet paper showed the results, which ended up in what is shown here as the message. Nothing is superior to aspirin for stroke and other endpoints. Those are the studies comparing one of the P2Y12 inhibitors with aspirin, randomized, of course, and you see the combined result of all of them does not leave the midline down here and does not favor one of the inhibitors or the group of the inhibitors in this slide over aspirin. So the very relaxing message is nothing is superior to aspirin for stroke and other points. This is the endpoint stroke. I could show you this more or less exactly the same slide for vascular death, for all-cause death, or for myocardial infarction, all looking the same. Nothing is superior to aspirin. So within the group of the P2Y12 inhibitors, as I mentioned, are three drugs: ticlopidin, clopidogrel, ticagrelor, and even here you can remain calm. No difference between these three. So also within this large group, there's no one drug superior to the other one. So aspirin is the drug of choice, but only aspirin or double antiplatelet treatment, adding one of these three shown here, or ticlopidin is no longer on the market, but clopidogrel or ticagrelor. I'll show you the recent data on that topic. That's first pooled analysis that was in the JAMA Neurology in December 2019. Pooled analysis of the two randomized controlled trials addressing this issue. Patients were included in both trials with minor stroke or higher risk TIA. I'll come back to that later. High risk TIA means an ABCD score of at least 4, which some of you may not be familiar with, especially the non-neurologists, but I'll explain that later. So minor stroke, NIH below 4, or high risk TIA treated with double antiplatelet treatment for 90 days compared to aspirin alone. And the result is shown here. That's the cumulative probability of a new stroke, recurrent stroke. And it's surprisingly high in the aspirin-only group. Surprisingly high, 10% after 90 days. But that's the same result in all trials we have. 90 days, approximately 10% suffer a recurrent stroke after having suffered a first event, which was mild or TIA. 10% with aspirin and 7% with clopidogrel aspirin, of course favoring this combination in this patient group. But two things are interesting. One is this. Of course, you have an increase in bleeding events. It's only 0.2% here, and it was not significant even in the pooled analysis of these two trials. So there is an increase in the risk of bleeding, but it's certainly outweighed by the benefit of the combination. This is one thing you should keep in mind. And the other thing that you should keep in mind is shown in this graph here. Very, very different from the LDL paper I showed you before, where the two lines keep on diverging over 8 years. This is completely different here. The lines are no longer diverging, but run parallel after starting at day 21. So the combination has an effect, has a benefit compared to the mono treatment with aspirin only within the first 3 weeks in both studies, and of course also in the pooled analysis of both studies. Very interesting finding, showing that there's an active thrombus which heals and has a risk increase only for this period of being active and healing and not having healed already. So, and this results in the recommendation I will show you in a moment of the recent guideline updates. But first, before I address that, I'll show you the other one. That's the third P2Y inhibitor, that's ticagrelor, very fashionable at the moment. Similar study, patients were included with mild stroke or TIA and received aspirin, randomized aspirin or aspirin plus ticagrelor. And you see a benefit that is similar in this case, favoring the combination, the aspirin plus ticagrelor combination over aspirin only, especially in the patients with disabling stroke. But in this case, you have a clearly higher bleeding rate, which in this study was significant. So you see here the number of patients with a relevant bleeding event leading to a discontinuation of study inclusion was 87-75 in the ticagrelor plus ASS patients, and in the ASS only plus placebo, it was 17 and 13. So a clearly increased bleeding risk in one study compared to the 2-study pooled analysis I showed you before. And this results in the following guideline changes in the US and in Europe. I'll show you them. Recommendation 1 is the recommendation on aspirin plus clopidogrel in people with a non-cardioembolic minor ischemic stroke, NIH 3 or less, or higher risk TIA, ABCD squared 4 or more in the past 24 hours. We recommend 21 days of dual antiplatelet treatment with aspirin and clopidogrel, followed by one of both monotherapy thereafter, usually aspirin. Quality of evidence 4+, great scheme, that's the method. 4+, strong arrows for intervention. Now, regarding the ticagrelor, the recommendation 2 is a little bit weaker. You see quality of evidence moderate and strength of recommendation weak, but you can use it. I mean, certainly the study was positive, the TALIS study. So, but it's only one study and it has a significant risk of bleeding. People with non-cardioembolic mild to moderate ischemic stroke or high-risk TIA, in this case, the ABCD score had to be 6, or other high-risk features, meaning 50% stenosis of the internal carotid or intracranial atherosclerotic disease. We suggest 30 days of dual antiplatelet treatment with aspirin and ticagrelor, followed by antiplatelet monotherapy thereafter. So a little bit weaker, you can do it, but the recommendation is a little bit stronger in the European guidelines, at least. The Germans are similar to that. Next slide, where is it? Doesn't move. Sorry. Don't know why my slides don't move. now it moves. Okay, for some reason it stopped. But the double antiplatelet regimen should not become a routine, as mentioned here in the European stroke guidelines. And people, so there was 100% expert consensus in this regard, in people with acute non-cardioembolic low-risk TIA, or where the diagnosis is uncertain. All experts voted against the routine use of dual antiplatelet treatment because, of course, you have an increased bleeding risk, and the benefit only outweighs the risk in the patients I mentioned before, high-risk TIA and a minor stroke in the first 24 hours of treatment onset. The US guidelines are a little bit more defensive in this regard. I just show you this sentence. Intensive discussion in the US. This is the result. Double antiplatelet treatment is recommended only in very specific patients, including those with early arriving minor stroke or high-risk TIA or severe symptomatic intracranial stenosis. Of course, this is old knowledge from the Sampras trials, many years old. So they're a little bit more defensive, but still recommended in the patient group mentioned here. So now, next topic, head-to-head comparison of direct oral anticoagulants. Now you all know it's dabigatran, rivaroxaban, and apixaban. Those are the main three drugs. And there are now registries comparing the real-life use of these drugs. So this is not randomization. This is real-life use, and doing in large numbers of patients taking these drugs, do comparisons of those using one and comparing them against those using the other, and doing propensity matching. So it's not just comparison, it's risk matching based on Chad-Svask score and Hess-Bled score. So what comes out? Now, if you compare dabigatran versus rivaroxaban and look at the events to prevent, that's systemic embolism or stroke, as well as major bleeding, that's the one you should prevent by taking these drugs. And if you then look here, on the right side is bad, on the left side is good. So in these real-life comparisons in registries, it appears that rivaroxaban is a little bit worse in both regards, in stroke prevention, ischemic stroke prevention or embolism prevention, and in severe bleeding prevention. So that's a trend, at least. Next comparison, same studies and registries. Apixaban versus dabigatran. Again, right is bad, left is good. Here again, and that's the feeling of many of us, I think, in the daily use. Apixaban appears to be safer and more efficient, although this crosses the baseline, the zero line here, but it's at least the safety appears to be a little bit better in the apixaban compared to dabigatran. And of course, the third comparison that's missing now is the apixaban against rivaroxaban, and of course, that's how it should be. Again, here you have a mild advantage in a non-randomized comparison of apixaban over rivaroxaban. So it appears to me, and that's what in Europe the daily practice also is, that apixaban is the one that has a little advantage in the use, in the broad-based use in the population, with in Germany 10% people having atrial fibrillation, mainly due to the demographics and to old age. So next, I have still 15 minutes. This is for the clinical neurologists. I mean, some people may think TIA is a diagnosis. I mean, a good neurologist knows what a TIA is and what a non-TIA is, but that's not as easy as you think, because it's only based on history, and even experts, stroke experts, largely disagree on what they think is a TIA. If they, for example, interview the same patient, if you have the same patient interviewed by 3 stroke experts, one will usually disagree with the 2 others of whether this was about whether this was a TIA or not, what the patients tell you, because you're rarely a direct witness of the event. This is the definition. Sudden onset focal neurologic deficit, presumed vascular origin, less than 24 hours. And I would like to add, leaving no traces of infarction. That's the new definition, because if you see a DWI lesion, it's no longer a TIA, it's an infarction, because it leaves a trace of infarction, at least in the structural sense. So what would you think is this? A sudden transient weakness in face, arm, hand, or leg. Sudden transient motor weakness. Or a sudden expressive or receptive dysphasia. Patient cannot speak or doesn't understand, or both. Sudden loss of sensation in face, arm, hand, or leg. Sudden hemianopia or quadrantanopia, or sudden monocular loss of vision. So I'm quite sure that at least the neurologists would largely agree on that this is a classic. All of them are classic TIAs. I doubt whether there will be much disagreement on that. But what do you make out of this? A sudden isolated vertigo a patient tells you of for, let's say, 5 minutes. Sudden isolated unsteadiness of gait. Sudden isolated diplopia only. Sudden isolated dysarthria. Sudden bilaterally decreased vision only, or single segment, maybe hand, sensory loss only. All history, you only have the history given by the patient. What do you think that is? You will have tremendous disagreement on what even experts will tell you what this is. And that was in the Oxford Vascular study published in The Lancet. I will show you the result. All of these events were classified as non-consensus TIAs. You could also name them transient neurological attacks also, avoiding the TIA label. They named it non-consensus TIAs. So, but how to validate what is a TIA and what is not a TIA? What's the way of validating that? The only way is to look at a large population with events like this and follow them for a long period. That's one way to validate this diagnosis. And the other way is to do MRI and look how many percent of the TIAs or non-TIAs are DWI positive. And that was done by the great British colleagues from Oxford, really tremendous work. They all present every year, almost present something like that. In this case, in the Lancet 2021, they did MRI, DWI, they observed a population of 90,000 inhabitants in and around Oxford, and they get all of them. They get all TIAs and stroke of this entire population. They don't miss any. And they, in their TIA clinic, they did DWI in each patient who came in, and they showed that in 7% of the non-consensus TIA, these vague events, you find DWI lesions, and in most of the cases in the posterior circulation, so the vertebrobasilar circulation, also explaining why there's so much dissent in expert opinions on what the patient tells you about this posterior circulation event. So 7% in the non-consensus TIAs and 17% in the classic TIAs. So double as many patients in the classic TIA group have DWI lesions as in the non-consensus TIA lesions. But still, this already tells you that most of the non-consensus TIAs are probably real, true TIAs, which we don't recognize in many cases. And even the patient may not recognize them. And the second way of validating the TIA diagnosis is to follow the patients, in this case for 90 days. I showed you before that following a TIA, you have 10% risk of suffering a stroke in the next 90 days. And the amazing thing here is that the non-consensus events were followed by almost the same 10% risk as the classic TIAs did, shown by the red line. This is stroke risk, 90 days. Almost the same in the transient neurological attacks were compared to the classic TIAs, telling you that questionable events, sudden events, obviously carry a similar stroke risk as TIAs, so that most of them are probably true TIAs and should be treated with secondary prevention. I mean, that's why I present this here, because secondary prevention relies on a either objective stroke diagnosis or a history-based TIA diagnosis. Interesting also that among the non-consensus TIAs, the isolated vertigo or ataxia or isolated dysarthria. So vertigo, ataxia, and dysarthria isolated had the highest stroke risk and were as high as the classic TIAs, whereas isolated single segment sensory loss or bilateral decreases of vision were much less likely to be followed by a recurrent stroke. This is also a sort of a validation of the ABCD square score that I will show you in a moment. Let's jump to that. That's the ABCD square score, where 2 points are given for unilateral weakness or isolated speech impairment. So they knew what they did because they weighted these motor events, half-sided motor events and speech events stronger than other only sensory or visual events. And of course, the duration also counts, things like that. So I will stop here because I have only 5 minutes left. So the Lancet paper I showed you, the TIA paper, is also a good validation of the ABCD square score, which was originally described in 2007, by the way, by the same group. That's their yearly Lancet paper they bring out. That was the one of 2007, the ABCD square score, which has now today come to a new popularity because these double antiplatelet treatment trials have used it and have shown that only in them, in the high-risk ABCD square patients, the double antiplatelet strategy has more effect than damage, more benefit than damage. So what's in the pipeline? I will just touch this because it's 11 minutes past 8. There will be studies, maybe I can tell about them in the upcoming years, on factor 11 inhibition. That's a plasma thromboplastin antecedent, which may add to the antiplatelet drugs in secondary stroke prevention, ischemic stroke prevention. I will not go into detail for reasons of time. Maybe even more interesting thing is the cardiologists already use it, as you may know, colchicine, a very popular, very old drug in classic, even ancient medicine. Colchicine, very popular in cardiology right now because part of the problem of unstable plaques and atherothrombosis is inflammation, of course. And so this is now tested in neurology as well. And my prediction is, as in TPA and mechanical thrombectomy, and we will use it in a couple of years in addition to what I showed you before in secondary prevention. And the next thing, the speaker of tomorrow is included in this author crew here, author group, Professor Schweid. Next thing is atrial fibrillation. Of course, the more intensive you look, in this case with external electrocardiographic monitoring, but you can also use implantable devices. Of course, the longer you look, the more patients with atrial fibrillation you will discover. And the second trial shown here, or the last that I will show you, this will be a trial that will be finished in 2 or 3 years, I think, is the one looking at whether looking with implantable cardiac monitors for atrial fibrillation not only discovers more atrial fibrillation, but also helps reducing clinical endpoints in terms of recurrent stroke and embolism. That's the FIND-AF2 study. It's a German study. We're also part of it here in Frankfurt, where I'm currently speaking to you from. So this is my summary slide of the second part, secondary prevention. We have a new LDL target. Keep in mind, it's 70 milligram per deciliters in patients with some evidence of atherosclerosis. Nothing remains superior to ASS, aspirin, and antiplatelet monotherapy. There are certain patients, I explained who they are, for a 21-day treatment with double antiplatelets, aspirin plus clopidogrel or aspirin plus ticagrelor. If you are in doubt whether your patient tells you something that could be a TIA, it's likely that it was one, as shown by the Oxford people. And promising new options are in the orbit, factor 11 inhibition, colchicine, and more intensive than currently AF detection after a minor stroke or TIA. That's the end of my talk. And once again, thanks for giving me the time and your attention. And I'm happy to receive questions if time allows us to discuss. Thank you.
Thank you, Professor. It's very comprehensive talk you give it to us. You give us the data about the use of TBA in extreme stroke condition, how to prevent stroke, and the most important طبعا is prevention of stroke. You focus on mild and high risk TIA. What about the prevention of severe cases of stroke, moderate to severe stroke, either cardiac or not cardiac? When to start double antiplatelet, when to start the double antiplatelet, and when to start the anticoagulant after moderate and severe stroke?
We after moderate and severe stroke, we start antiplatelet treatment usually after a second CT scan showing that the patient has not bled into the infarction. So after a couple of days. But of course, in a severe stroke, usually also a large stroke, we would not put the patient on double antiplatelet because the bleeding risk is high and the benefit is of course lower because the thing that you should have to prevent already happened. So the benefit risk ratio is worse in the large strokes. We only do it as explained in the studies in high-risk TIA and minor stroke for NIH 4 or less.
What about the oral anticoagulant for embolic stroke? When to start the oral anticoagulant?
Very different question. I tried to avoid this in my talk because we don't have firm data that allows a definite answer to that. If a patient has had a transient event, I would start with and I know that it's due to atrial fibrillation, I would start him on immediately if he has no infarction, so let's say TIA. And if he has a small stroke, I would start him after, and I know that it has no bleeding after 1 week. We do a CT after 1 week, let's say, and has not developed a bleeding. We would start him after 1 week. If it's a large stroke, we would wait for another 2 weeks, at least 2 weeks after the stroke happens. But this is just this is nothing where you can write a good guideline on because there are studies around now, the RESTART trial, for example. Maybe we know firm data about this in the future, but it's a matter of feeling, I would say, right now.
We have a lot of questions for Professor Helmus. The first question is: a patient having optic disc edema following cerebral. Okay, we have this following cerebral edema, which associated with severe hypertension, is reversible.
Severe cerebral edema due to ischemic stroke.
Yeah, he said optic disc edema following cerebral edema associated with severe hypertension. Is it reversible?
That's a very difficult question. Optic
disc edema.
Edema.
Yeah.
Edema.
Yeah.
Not ischemia or infarction, edema. I'm very
following cerebral edema.
Yes, prolonged cerebral edema.
Yeah.
It is reversible.
Yeah.
But of course it is reversible. It will end up in infarction. But the patient, of course, will have a period of very high risk of dying of that by herniation. And if the patient is young and otherwise healthy enough, we would consider a hemicraniectomy in some of these cases to not let them die.
Yeah. he said also if it is curable or not after a good control of blood pressure. And most probably it is related to severe hypertension, not related to stroke.
No, I don't think so, because the relevant part of the edema after cerebral infarction is cytotoxic edema, so it's intracellular swelling. This will maybe improve a little bit by lowering blood pressure, but this is not the solution to the problem.
Yeah. Okay. Another question: did aspirin is recommended and useful for a diabetic patient or no?
For a diabetic patient? Yeah.
Maybe.
Yes, it is. Yes, it is. Some diabetologists think, based on the Capri study, that's a very old study, because there was a subgroup of diabetics who apparently had a little bit more benefit from clopidogrel over aspirin. Some diabetologists prefer clopidogrel over aspirin in diabetics and secondary prevention. All the studies that I have shown to you in all the guidelines do not make this point, so they don't discriminate between diabetics and non-diabetics.
Maybe the patient is having no stroke, just to give it as a primary prevention. The diabetic patient, because sometimes they are giving aspirin to diabetic patient as a primary prevention of a stroke.
If you have no vascular event and no evidence of atherosclerosis, I would not do that.
Okay.
It was fashionable in some decades ago, but one per 1,000 patients per year taking aspirin will die from it due to gastrointestinal bleeding or intracranial hemorrhage. So you shouldn't do this as a primary prevention.
Another question: can we give a dual antiplatelet in the second attack of TIA?
Sorry,
giving dual antiplatelet or double antiplatelet in the second attack of TIA?
If it's a high-risk TIA, yes. If not, no. I mean, still, aspirin reduces the risk of suffering a second event by only 15%. So it's not that it's 100%, as never in medicine. So if a patient suffers a second attack under aspirin, I would continue giving him aspirin. Some will switch him to clopidogrel, I know, but I mean, there's no data on that. So I would continue him on the regimen he was on.
Okay. What is a bridging therapy? Another question: what is a bridging therapy after stopping antiplatelet and anticoagulant for stroke before elective surgery?
In aspirin, we use aspirin and clopidogrel. We wait for 5 days. That's what the surgeons tell us, because they say you need 5 days before aspirin or clopidogrel treated patients are safe for vascular surgery, unless it's an absolute emergency. The only exception are some vascular surgeons operating on the carotid. They continue them on aspirin because they prefer operating them on aspirin because this reduces the likelihood of an atherothrombotic stroke immediately after surgery or during surgery. Of course, it increases the bleeding risk, but reduces the thrombotic stroke risk.
Another question, this from me. Regarding the aspirin, it is related to the body weight. This means if the patient is low, his body weight is big, or high body weight, as aspirin 81 is not enough, he has to take more aspirin, more dose of aspirin, or the same, the dose the same for all the body weight?
Very interesting question. And there was a paper 2 or 3 years ago, also by the Oxford group in Lancet, addressing this. And there are strong signs, I would say, that aspirin in the usual dose of, let's say in Germany, it's 100 milligram per day, maybe not enough for the patients above 100 kilogram, above 80 kilogram. So it makes sense to put the heavy overweight patients on a higher dose than 100 milligram. But this is just a personal statement. It's not written in any of the guidelines because nobody has ever investigated this prospectively, and it will be very difficult to do that. So this is just a personal feeling. My personal answer to the question that you asked is yes, I would put the overweight patient on a higher dose But if you ask me where where's the guideline that tells us that, there is none.
Thank you, Professor. Dr. Majid and Dr. Said, do you like to share? Do you have any question for Professor Helmus?
No, thank you.
Dr. Majid, do you have any question? Okay. Thank you very much for your attendance today. Thank you, Professor. Thank you, Dr. Said and Dr. Majid, and all the attendees. Thank you for our organizing committee. We'll see you, inshallah, tomorrow for the other symposium from 7 to 9 also, same time like this. Thank you very much, everybody, and see you tomorrow, inshallah.
As-salama.